Welcome back. Okay, if you're gearing up for the boards, or honestly just need to absolutely dominate your next clinical rotation, you are in the exact right place. Today's explainer is a rapid-fire board review for Clostridioides difficile, or C. diff. We're going to pack the next few minutes with high-yield traps, critical warning signs, and the exact clinical blueprints you need to score in the top percentiles. We're breaking down the mechanics of the infection, bypassing all the fluff, and getting straight to the high-stakes testable material. Grab your focus because we are moving fast.
Okay, let's dive right into this. Here is our clinical syllabus for today. First, the 3-event pathogenesis. Second, diagnosis and exam traps. Third, severity warning signs. And finally, the 2021 treatment hierarchy.
All right, Section 1, pathogenesis events. We're talking about the 3 required hits. So, symptomatic C. diff infection, it's not just some single unfortunate event. It actually requires a perfect storm of 3 sequential hits. First up, you need antimicrobial exposure to disrupt the normal colonic microbiota, to create that ecological niche. Second, exposure to toxigenic spores. And remember, these spores are incredibly resilient. They easily survive stomach acid and can literally live in a hospital environment for months. Oh, and hand sanitizers? They won't kill them. You need good old soap and water. And third, the patient has to have an inadequate host immune response, specifically a low IgG antibody level against the toxins. If any one of these 3 is missing, sure, you might get colonization, but you do not get symptomatic disease.
Now, while technically any antibiotic can trigger C. diff, even vancomycin itself, the boards absolutely love to test the highest risk offenders. Take a mental screenshot of this mnemonic. Frequent C. diff causes. That stands for fluoroquinolones, clindamycin, and cephalosporins, specifically the 2nd and 3rd generation ones. In fact, fluoroquinolones are the most recent class heavily implicated in driving massive hospital outbreaks. So if you see a patient scenario with recent use of these drugs, followed by diarrhea, C. diff should be flashing in neon lights in your brain.
Okay, let's talk about the actual weapons C. diff uses, because the molecular mechanism here is heavily tested. C. diff produces 2 main toxins, A and B. Toxin A is an enterotoxin and a pretty potent neutrophil chemoattractant. But Toxin B is the absolute star of the show. It's a cytotoxin that glucosylates Rho GTpases. Basically, it completely disrupts the cell's cytoskeleton, loosens tight junctions, and causes massive fluid leakage. Here is your high-yield takeaway. Toxin B is the essential virulence factor. Strains missing Toxin A, they can still cause disease. But strains missing Toxin B, no way. They do not.
Let's see how this builds into literally one of the biggest exam traps out there, the infant paradox. Picture this. You get a clinical vignette about an infant under 2 years old with diarrhea, and the lab shows C. diff colonization. Do you treat? No, absolutely not. Infants are frequently colonized with toxigenic strains, but they almost never get sick. Why? Because they literally lack the mature mucosal toxin receptors needed for the toxin to bind and actually cause damage. Testing infant stool for C. diff is highly unreliable and, honestly, a massive diagnostic misstep. Don't fall for it on test day. Moving on to Section 2, diagnosis and traps. It's all about avoiding overdiagnosis.
All right, let's test your clinical instincts with a classic scenario. You've got a patient with loose stools, maybe from a completely different cause, like, say, laxative use, and their C. diff PCR test comes back positive. Why doesn't this automatically mean they have an active C. diff infection? Well, the answer really comes down to the sensitivity of the test. A PCR, or nucleic acid amplification test, is incredibly sensitive, but it only tells you if the toxigenic gene is present. That just means it detects simple colonization. If a patient is merely colonized but has diarrhea from some other cause, relying just on PCR is going to lead to massive overdiagnosis. That's exactly why the recommended algorithm is a 2-step process. You often screen with glutamate dehydrogenase, or PCR, but then you absolutely must combine it with a stool toxin enzyme immunoassay, an EIA, to confirm that the toxin is actively being produced. That is what signals a true infection. So the crucial point here is knowing what not to do after you've actually successfully treated the patient. Here's the cluster of high-yield, do not do this moments. Tests of cure? Absolutely not recommended. Why? Well, because more than 50% of patients will still harbor C. diff and its toxin even after their symptoms have totally resolved. A positive post-treatment test just doesn't predict recurrence. And practically speaking, never restrict a patient's placement into a nursing home based on a positive test of cure, even if the facility is begging you to. Always treat the patient's symptoms, not their lingering lab results.
All right, Section 3, Severity Warning Signs. We're looking at strict clinical criteria here.
I need you to lock this number into your brain right now. 15,000. If a patient's white blood cell count hits 15,000 per microliter, or alternatively, if their creatinine jumps to 1.5 milligrams per deciliter, they instantly get bumped from mild-moderate to severe CDI. It doesn't even matter if they've only had a few loose stools. Those lab values dictate that you have got to initiate aggressive therapy promptly. Do not delay.
And this brings us to a frankly terrifying clinical reality and a massive favorite for board questions. Fulminant or severe complicated CDI often presents completely without diarrhea. Yep, you heard that right. An ileus can form halting stool passage entirely. The patient might present with an acute surgical abdomen, systemic toxicity, and an unexplained leukocytosis of maybe 20,000 or more. If you see a patient on antibiotics who suddenly develops an acute abdomen and a skyrocketing white count, even with zero diarrhea, you have got to urgently investigate for C. diff. Now, here's the absolute critical threshold for surgical intervention, 5. If a patient is in fulminant failure, you're obviously tracking their serum lactate. If that serum lactate is rising and hits 5 millimoles per liter, that is the exact threshold where a surgical colectomy must be considered. Waiting until it goes any higher dramatically increases mortality. Remember, a lactate of 5 means they might not survive. It's the surgical threshold for a colectomy. Keep a very sharp eye on that lactate. Finally, Section 4, Treatment Hierarchy, recovering the 2021 IDSA and SHIA guidelines. Okay, here's the modern treatment map, and this brilliantly illustrates the whole thing. Notice how fidaxomicin is now the absolute king here. For a primary episode, fidaxomicin is first line, though oral vancomycin is an acceptable alternative. For a first recurrence, fidaxomicin is superior simply because it boasts a lower recurrence rate than vanco. And notice something else? Metronidazole is virtually gone from these early steps. It's just no longer recommended for recurrence. For multiple recurrences, you're looking at prolonged fidaxomicin tapers or fecal microbiota transplantation, FMT. And for fulminant CDI, you hit them from every possible angle: oral or NG vancomycin, vancomycin enemas, and IV metronidazole. Let's pause for a second for a classic pimping question. You're on rounds, right? And the attending asks, hey, why can't we just give this patient an IV vancomycin drip for their C. diff? Do you know the exact pharmacokinetic reason why that fails? Well, here's the answer. IV vancomycin is not secreted into the colon in adequate concentrations. C. diff is a colonic mucosal disease, right? So the drug literally has to act locally. You have to get the vancomycin directly into the gut tube, via oral, nasogastric, or enema delivery. Now, contrast this with metronidazole. We do use IV metronidazole for fulminant cases because unlike vanco, IV metronidazole actually is secreted by the intestinal mucosa right into the colon. Knowing that distinction is pure exam gold. Now, let's check out a newer biological therapy, beziloxumab. Remember back in step 3 of pathogenesis, we said patients get symptomatic because of an inadequate host immune response, specifically low IgG? Well, beziloxumab is an IV monoclonal antibody that specifically targets toxin B. It essentially substitutes for that inadequate humoral response we talked about. It's given as an adjunct right alongside standard antibiotics, and it reduces the absolute risk of recurrent CDI by about 10% in high-risk patients, like the elderly or the immunocompromised. Okay, before we wrap up, I'm throwing one last rapid-fire microbiology question at you to really secure those top percentiles. What's the name of the notorious epidemic strain of C. diff that is highly fluoroquinolone resistant and pumps out 16 to 23 times more toxin than standard strains? Yep, that would be the absolutely devastating NAP1/BI/027 strain. Not only does this thing produce massive amounts of toxins A and B, but it also contains an extra weapon called the binary toxin, CDT. Its rise was heavily linked to the widespread use of fluoroquinolones in hospitals, and it spread globally like wildfire before stricter antibiotic stewardship finally started bringing its numbers down. And there it is. You now have the complete clinical blueprint. By really grasping the true mechanisms, from why infants don't get sick because they lack receptors, all the way to the pharmacokinetics of oral versus IV delivery, you don't just memorize the rules, you understand the why behind them. That is the ultimate cheat code for the boards and for the wards. So, my final provocative question to you. Given how heavily relying on clinical suspicion over simple lab tests matters here, how will this change your approach the next time you see an unexplained high white count in a post-op patient? Think about it. Keep studying smart, and we'll see you in the next explainer.